MPN Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the MPN Hub podcast. Today we'll be hearing from Laura Michaelis of the Medical College of Wisconsin in Milwaukee, US, and Claire Harrison of Guy's and St Thomas's NHS Foundation Trust in London, UK.
Thank you so much. Yes, I'm Laura Michaelis. I'm at the Medical College of Wisconsin, where I focus on myeloid diseases, including myeloproliferative neoplasms. And I'm here with Claire Harrison. Claire?
Hi, I'm Claire Harrison. I work at Guy's and St Thomas's Hospital, which is in central London, and my main focus is also on myeloproliferative neoplasms. It's great to be with you today, Laura.
Absolutely. Even if it's virtual, one of these days we'll get back to real life. So we had hoped to spend a little bit of time today talking about some of the best practices in MPNs and maybe rolling in some of the new data that we got from the American Society of Hematology meeting last month. So I want to start with just some sort of best practices in diagnosing MPNs. And one of the things that comes up in what I see is not everybody's getting a bone marrow biopsy, and some people are getting next generation sequencing done no matter what stage of the disease. So let's start there a little bit. Claire, who do you think needs a bone marrow biopsy when somebody has been told they have a myeloproliferative neoplasm, either PV, ET, or myelofibrosis?
I think it's really important to be absolutely certain about the diagnosis, or as certain as you can be. And if you can't be certain, say you're not certain, and call the patient MPN, NOS, or unclassified. And I absolutely think that getting a bone marrow biopsy is a really important part of that, not just to say, oh, this patient's got a high platelet count, they're JAK2 positive, they must have ET, because sometimes, some subtleties can be missed that can be found in the biopsy, so increase in fibrosis, and there can be other features that can come to light. So these can be rare things like mastocytosis, which can commonly co-present with an MPN, or sometimes, taking, for example, myelofibrosis, a misdiagnosis of CMML, which would be managed differently. So I think it's useful to do a bone marrow biopsy for the vast majority of patients, also from the perspective of having a kind of baseline test, should things change in the future. But the other things that we do at diagnosis, Laura, are also sort of genomic testing, aren't they? And there's a temptation to, want all the information you possibly can and think about, allele burden and then wider genomic screening. So what are your pearls of wisdom on that?
Yeah, so first off, I just want to concur that I also encourage every person I see who either is referred with a diagnosis of myeloproliferative neoplasm or where we're considering that to undergo a bone marrow biopsy, not only because I agree that the absolute, as clear a diagnosis as you can have, but I also think it matters quite prognostically. So for example, the difference between a pre-fibrotic myelofibrosis and essential thrombocythemia, those may look the same from peripherally. The marrow itself is sometimes different, but importantly, the overall trajectory of that person's disease is different. We know that ET and pre-fibrotic myelofibrosis behave differently, and pre-fibrotic myelofibrosis and frank fibrotic myelofibrosis behave differently. So I feel like it's an important part of that the diagnostic biopsy in all conditions of MPN is indeed important. In terms of next generation sequencing, so I generally tell my patients that for the time being, NGS is predominantly a prognostic marker, not a diagnostic marker. And so the initial workup of diagnosis doesn't necessarily need to include it. Now, in myelofibrosis, in patients where I'm considering a stem cell transplant, I do think about that because of our new scoring system. For example, the MIPSS 70 incorporates next generation sequencing and can really give us a very reliable way to look at the overall survival in the next 5 years, and can also give me some additional information about making a key and difficult decision about when to refer a patient for stem cell transplantation. At the current time, next generation sequencing, while maybe prognostically important, isn't as relevant in a patient with polycythemia vera or ET. So unless it's in a research setting, I don't typically send off NGS in those two patient populations. Is that the same as your practice?
Yeah, I absolutely agree. I was just thinking as you were talking, I think a really tricky area is the triple negative patients with a thrombocytosis. And these are often young women. And we were having a really interesting discussion peri-ASH about that in the UK, actually. And here I think many of us would shy away from doing a biopsy. I think it's really important because if you don't see characteristic features, you can be certain that pretty much that the patient doesn't have ET. And I also wanted to make the comment that I actually don't think an NGS is helpful there unless there are, mixed features or you're not certain. Right. Because most times we won't find anything, and most times we won't find anything in an ET or a PV patient where we want to, we're tempted maybe to tick the box and get the test.
Right. Yeah. So let's just shift over. I want to talk about incredibly common situations that I see in the clinic, and that is a patient with myelofibrosis where the primary problem is anemia. And so this is a patient who's got maybe a 2+ fibrosis in the marrow, an enlarged spleen, a hemoglobin in the low 8s or high 7s, who's symptomatic with fatigue. The large spleen may be contributing a little bit of that anemia because of some hemolysis, as you might get some hemolysis from the marrow. That's a person who's symptomatic, and yet when I put them on a JAK inhibitor, I'm concerned about additional anemia. So we have this is certainly an area of incredible research going on recently. We've got some new therapies possible. We've got one new JAK inhibitor that is trying to position itself in particular for the person with anemia at diagnosis. I'm wondering if we can talk a little bit about some of the novel agents that are being considered in the anemic MF patient. For example, pelabresib, which people have heard about for a few years now, luspatercept, for example, as well as momelotinib. And you've worked with momelotinib a lot. Maybe we can talk briefly about that agent and how it compares to the other JAK inhibitors that are out there.
Sure. Well, I think anemia is really a big area of unmet need. And one of the things I always say to people in my clinic, though, is don't assume it's just due to the disease. Don't get caught out with somebody with bleeding varices, and always check the hematomas. And yet we still get caught out from time to time, right? So I think momelotinib, I'm really waiting for the results of the Momentum study. So just in many ways, this is similar to ruxolitinib, but it targets the hepcidin pathway, and really learning a lot and focusing a lot on the iron pathway, aren't we? And factors that influence that. So certainly appears to deliver similar spleen and symptom responses and maybe be able to alleviate disease-related anemia, currently being evaluated in the momelotinib study. And that's one of the things that I'm looking forward to hearing about going forward. I mean, in terms of other agents that we've been looking at, there are, of course, the luspatercept story is really interesting in the MDS setting and in the thalassemia setting. And ASH, there was some more final data from sotatercept that was presented by the MD Anderson group. And I think potentially luspatercept being taken forward in combination with ruxolitinib or another agent, fedratinib, for example, in MF is interesting. What do you think about that, Laura?
Yeah, I did pay particular attention to the luspatercept and sotatercept data. That's agents that are relatively straightforward to give. They don't have a lot of side toxicities, not a lot of overlapping toxicities. The luspatercept data, I think it was presented by Dr. Gerds, that phase 2 study, wasn't a huge number of patients. I think about 40 or 41 patients total, with endpoints in those that were transfusion dependent of becoming non-transfusion dependent, and in those that were non-transfusion dependent of about 1.5 grams of increase. And I think the results were in about the 20% range on both groups, but they didn't see a lot of toxicities. So I think that's, may be good for some of the patients. Even if they didn't meet that strict 1.5 gram above, they did become less anemic. And as you know, patients can really be quite sensitive to that. The sotatercept data, I think the final data out of MD Anderson said about a 30% response rate of using that agent. Again, it is IV, which is a problem, but every 3 weeks or so, and not a huge number of toxicities. I've been involved in the pelabresib study, which is the study of a bromodomine inhibitor in combination with ruxolitinib. And we've had results published, or I guess at ASH, the last two on that, which does see, again, not only spleen reduction, but improvements in transfusion-dependent arms, both in combination and in the monotherapy agents. So that also, I think, is probably coming to be approved to be used as a doublet, probably sometime in the next 2 quarters, at least from my understanding, that particular agent. We may see more bromodomain inhibitors. The other thing that's interesting is this, as you mentioned, the Herceptin pathway. We're seeing, interestingly, both the Herceptin pathway being upregulated for patients with PV, for example, novel agents to try and keep their anemia, to provoke anemia, and then trying to prevent the Herceptin pathway in patients with myelofibrosis, given that this kind of classical anemia with chronic disease or anemia of inflammation is at play in those patients.
Yeah, I think that's super interesting, isn't it? And manipulating that pathway in PV and some agents which can maybe alleviate the need for venesection. But really importantly for me, it was about alleviating the symptoms of iron deficiency for those patients, so pruritus, fatigue, etc. And all of these agents are kind of ongoing in clinical trials. And another area I just wanted to highlight, we haven't seen a new drug for ET for a while, have we, Laura? So
no, right.
In fact, more than a decade, maybe 2. Super excited to see the LSD1 inhibitor bomedemstat being looked at for ET patients. So that's, as we've tested that in MF, and maybe you've also been involved with that, I think, and we titrate that drug dose against the platelet count. So it seemed a logical next step to look in ET patients. And so there was data presented at ASH showing nice responsiveness of the platelet count, some also just looking beyond the normal, so beyond platelets and symptoms, and also some molecular data. And just kind of tying into the last conversation about bromodomain inhibitors, pelabresib is also being tested in ET patients. So important because there are very few treatment options for those patients, and also as a practice point, being aware that the patients who are refractory to treatment often have a really bad outlook.
Absolutely, absolutely. Well, I think we're bumping up on our time here. I want to thank you, Dr. Harrison, for taking the time. It's always good to kind of have a chance to reflect on what's new coming down the pike, and also get back to the basics. As I'm sure you do, I talk to my trainees. The first step is always diagnosis. The second step is risk stratification. And the third step is treatment. And so making sure that we're all doing the basics for risk stratification and diagnosis before we move to some novel, interesting, and compelling treatments is great sort of basic reminders.
Absolutely. It was a pleasure to join you.
Absolutely pleasure. Thank you so much.
Thank you. Bye-bye.
Thank you for listening to the MPN Hub podcast. We would also like to thank our supporters, Bristol Myers Squibb and Novartis.
MPN Hub podcasts, brought to you by Scientific Education Support.